Good afternoon, everyone. Welcome to AEI. It's a pleasure to have you all here today for today's discussion. I'm Ryan Streeter. I'm the Director of Domestic Policy Studies here, and I'm honored to be joined by Senator Mike Lee from Utah, who will offer some remarks today on a new report that's been issued by the Social Capital Project, which he launched in his role as Vice Chairman of the Joint Economic Committee. The Senator will offer some remarks, and then he will be followed by a group of distinguished panelists that we have here today. After his remarks are finished and he's left the stage, I just ask that you stay seated while the panelists come up, and we'll do a quick transition. The report that the Social Capital Project has released is about the numbers behind the opioid crisis. If you haven't read it, please do. I think you'll find it really interesting, as well as the other reports that the project has put out. Senator Lee was elected to the Senate to represent Utah in 2010, serves on the Commerce, Judiciary, and Energy and National Resources committees, in addition to his role as Vice Chairman of the Joint Economic Committee. And before coming to the Senate, he had a distinguished career, which included practicing private law, clerking for Justice Samuel Alito, acting as the Assistant U.S. Attorney, and also as the General Counsel to Governor John Huntsman. So we released the very first report of the Social Capital Project last year with Senator Lee, and so we're delighted to welcome back to AEI to talk about this latest report. Senator Lee, welcome back to AEI.
Thank you very much. Thanks for that kind introduction. Thanks for letting me join you this afternoon. I always enjoy being at AEI, and I always think about Arthur Brooks whenever I come here. And in honor of Arthur, I wore the craziest pair of socks I could possibly find. These are Utah socks. Let me explain. You'll see crickets and seagulls on them. Crickets and seagulls have a lot of historical significance for my state. When the first Mormon pioneers arrived in the Salt Lake Valley in 1847, they got right to work. There were supposedly only 2 trees in the entire valley. They started planting their first round of crops. There wasn't much growing there, so they nearly starved to death. And when the next growing season came, around in 1848, a big swarm of crickets came. I learned later in life these weren't actual crickets. It's a closer relative to the katydid. Their wings are ornamental. They can't technically fly. They sort of glide. But they devour everything in their path. It's an insect that destroys crops. Now, this is land that had never been inhabited by the descendants of Europeans. It had been sparsely inhabited by Native Americans, and they didn't know how to grow things. They didn't know how to avoid this sort of thing. So in 1848, they could see that they were at the point of starvation when a big, huge flock of seagulls showed up. I don't mean the band from the 1980s, although their hairdos looked a little bit like that. Huge flock of seagulls showed up and ate all of these crickets, and they would gorge themselves on them. And when they were finished eating, they would go and regurgitate them and come back and eat more. And it's regarded as a miracle. It doesn't have a whole lot to do with the opiate crisis, but it just gets back to my socks, which I wore in honor of Arthur. In some ways, though, the story reminds me a little bit of the opioid crisis. We've got a very big challenge to deal with opioids in the United States, and I'm honored to come and speak here on this topic. AEI is home to some of our nation's foremost scholars and thinkers, and that's why it's especially rewarding to get to have some of this discussion here. And there are a few issues that are more overwhelming, more potentially depressing, and more in need of our public attention than this one. I can think of few better qualified experts to comment on these than those that have been assembled for this event. And I'll admit I'm biased in the case of Scott Winship, who directs the Social Capital Project that I direct as Vice Chairman of the Joint Economic Committee. But thank you, Ryan, for putting this together. And I want to thank Yuval Levin and Sally Sattel also for contributing their wisdom. I want to give make sure that the true experts have most of the time here, but I thought I'd preface this discussion with a few thoughts about this terrible crisis and the damage that it's doing to our communities. For a more in-depth treatment of this important topic, I'd recommend you to the report that Scott put out along with his team about a year ago called The Numbers Behind the Opioid Crisis. I commend the whole thing for your attention. But I want to start with a story about an American veteran. It's a veteran who took up arms for his country, and he was critically wounded during a time of war. He had seen friends die right in front of him. On several occasions, he himself had nearly died in the battlefield. And when this veteran finally returned home, the war seemed to come home with him. He could hardly eat because of the terrible pain in his stomach. After bouncing from one doctor to the next, this particular veteran got hold of some opiates. And when he tried to quit, he found himself, as he later discovered and as he later commented, in the fangs of a monster. This veteran's addiction tended to isolate him from everyone else around him, from his family, from his friends, from his neighbors, from his fellow veterans. And this description that he provided is quite poignant. He described himself in the following way. He said that he was, quote, in life but not living, irretrievably cut off from almost every social enjoyment, close quote. This veteran's story is interesting. And one of the many reasons why it's interesting is because of when it happened. Because this was not a veteran who was returning home from war in Afghanistan or in Iraq or Vietnam or in Korea. No, this was a Union drummer boy who was introduced to morphine, a powerful opiate, in 1867. He was still addicted when he published an anonymous memoir a decade later after first being introduced to this force that would ravage or wreak havoc on his life. This young man was a casualty of what we might appropriately think of as America's first opiate crisis, which at its peak, which I'm told was reached in the 1890s, gripped more than 300,000 Americans. This crisis was caused, at least in part, by a massive and rather sudden flood of opiates during the Civil War. By one estimate, the Union Army had requisitioned 10 million opium pills for its 2.6 million soldiers. That's a lot. But just as importantly, this crisis was caused by the social turmoil that followed inevitably in the aftermath of the war. It's what came after the war that helped contribute to this massive crisis taking hold and bringing about so much destruction. You see, in addition to their physical wounds, Americans in the North and in the South were dealt gruesome relational wounds as a result of the Civil War. There was an entire generation of young men, friends, brothers, fathers, nephews, uncles, who vanished from American communities, seemingly overnight. Additionally, the war robbed a whole lot of Americans about their sense of purpose and their collective sense of certainty, something that to that point in their lives had animated their souls, had given them meaning and purpose in life. Their loss was spiritual as much as it was physical. All of these cultural factors left 19th century Americans very vulnerable to addiction, just as a ready and abundant supply of drugs was becoming available and easier to use and more accessible. So these two things fused together in a way as to create a sort of perfect storm. I believe something similar is going on in our opioid crisis today. One critical difference, of course, is that our current crisis is far more widespread and far, far deadlier. You see, between 1999 and 2016, 632,000 people in this country died from drug overdoses. That's a higher body count than the Civil War, who have died just in the last 2 decades. This American carnage has been fueled by rising overdose rates for all kinds of drugs, including not only opioids, but also methamphetamines and cocaine. So we shouldn't assume that this is only an opioid crisis, because it's not just that. There is more to it. But make no mistake, the main drivers of this crisis are, in fact, opioids, which in and of themselves killed more than 350,000 people over that same 17-year period. So the majority of them were killed, in fact, by opioids. Scott and his team have put together a really powerful visual aid to show how opioids have spread across the country in the last few decades. And I think we have it up on the screen. Let me see here. Let me explain what it is that you're going to see. We take data starting from about 40 years ago, in the late 1970s, when this data first became available. And we measure by county the number of opioid overdose-related deaths. Starting back then, if there were a measurable number, between 1 or 2 and 4 or 5 opioid overdose-related deaths in any one county, it would show up as a sort of light pink color. And then as those death rates get up to between 5 and 10%, they get a darker red. They reach their deepest red level as they approach 13 or 14 overdose-related deaths per 100,000. And what you're going to see is this starts in just a couple of counties, just a small handful of counties, mostly on the coasts, and then something interesting and terrifying happens. Watch. Let's watch it one more time just for, well, maybe it'll come back. Yeah, there you go. I think I see it again. Just on the coast, and then you see these islands, initially of pink, and then of deep, dark red. Now, a lot of these communities are some of the last places where you would expect to see some of this crisis be at its worst. And yet, very few communities are spared. Now, keep in mind, most of the white that you see, the counties that are truly white, are in fact counties where the data isn't available for one reason or another. In many cases, because in a lot of those counties, the population is sufficiently sparse that it becomes almost impossible to anonymize the data. And so privacy concerns prevent its release. But what you do see is many, if not most, if not nearly all of the counties where there is a sufficiently significant population that you can anonymize this data are suffering as a result of this. I look at my own state and I see that nearly every part of the state that is somewhat well populated has the issue. So this is not limited to certain urban islands of abuse. This is all over the place. The map shows the magnitude of what we're up against better than any bare statistic ever could. We're in the midst of the deadliest drug wave in history, and it's been caused by the deadliest drugs in history. Those include the prescription pain pills that we've heard so much about, like oxycodone, which were involved in 14,000 deaths in 2016 alone, and heroin, which was involved in 15,000 deaths that same year. Then there's the deadliest of all, the synthetic opioids, which were involved in over 20,000 deaths since 2016. The most common synthetic opioids on the street are fentanyl and its derivatives, which are themselves 50 to 100 times stronger than the morphine that hooked soldiers during the Civil War. These drugs are so powerful, they're so potent, they can in some cases kill you through skin contact. In other instances, first responders, police, EMTs, and others can have an accidental ingestion just responding to a scene where this occurs. Another problem we have is that the people who cut these drugs, the dealers, and mix it with other substances, if they're not really careful about how they cut it, the difference between a really severe high And an overdose that can cause death can be the weight and volume equivalent of a couple of grains of salt. And in many instances, the dealers aren't really all that precise about how they cut it. That's one of the reasons why these deaths are occurring with such in such great numbers in a way that's very troubling. The most common synthetic opioids, in other words, exacerbate the risk. And there is this phenomenon known as the prohibition effect, that when things are prohibited over time, the dealers, the distributors of something that is contraband will make it more potent because it's easier to traffic, it's easier to avoid detection, and so they do it. This has a dark side, and it shows up in the form of these very severe and sometimes difficult to predict opioid overdose deaths. Fentanyl is especially easy to conceal and traffic in because it's so potent. It's a good drug for dealers, and it's a bad drug for users. It's cheap, and they can mix it in with something else, and their product will become known as fairly potent. But if they do it wrong, they're going to kill their own customers. In one of history's really grim ironies, most of this fentanyl that's being sold within our borders comes from China. This is a civilization that was itself hobbled in the 19th century by Western opium imports, including more than 1 million pounds of imported opium products from the United States. Now the shoe is on the other foot. Fentanyl from illegal Chinese laboratories crosses into our borders every single day, and often it's not smuggled in on ships in the way we would traditionally think of drug smuggling, or in the way we would, you hear about these makeshift vessels that are created by drug cartels in Central and South America. No, a whole lot of these are just mailed in an envelope through a parcel system, through regular U.S. mail or one of the other couriers. These drugs are the supply, and the crisis could not have ever happened without them. But just as important as focusing on the supply is also focusing on the demand. Who is it who's overdosing on these drugs? And why are they turning to drugs in the first place, which with such eagerness, such aggressiveness, such dangerous fearlessness? The people most vulnerable to opioid addiction are often lonely and cut off from sources of personal fulfillment. And by that I mean family and meaningful work and engagement with friends and with neighbors. Individuals who are divorced, for example, who are divorced or who have never married in the first place, make up about 32% of American adults. But they account for an astonishing 71% of all opioid overdose rates, deaths in the United States, meaning they are more than twice as likely as their numbers would otherwise suggest to fall victim to an opioid overdose death. Similarly, individuals with no more than a high school education are disproportionately likely themselves to die from an opioid overdose. For most people, prescription drug pills are the most common entry point to opioids. This is a particularly big problem in my state, where I recently met with the special agent in charge of the DEA in Utah, who, not himself being from Utah originally, having served there for a few years, said, this is different than some other markets. Most of the people in your state would never dream in the first instance of going out and buying something from some guy in a parking lot that they had to inject, or even something that didn't look familiar. But they're comfortable taking something that is official, that looks official, that has a prescription on it, that has a commercially generated label on it, and is itself commercially produced. But once they get in that way and they're hooked, then in many instances they'll do whatever they have to in order to continue to get a supply, including possibly meeting up with some guy in an empty parking lot. But as Dr. Sattel has noted, most people don't get their pain pills ultimately through a legitimate prescription. They may start out that way, but when you look at all users and what they're using, they're buying them through means that are not legitimate. Rather, a majority gain access to pain relievers through perhaps initially through a friend or a neighbor, and later perhaps through a stranger in an arm's length commercial clandestine transaction prohibited by law. So a teenager might steal pills from his parents' medicine cabinet, or a well-meaning individual might give some of his prescription pain pills to a neighbor in time of need when the neighbor is in pain. This is a curious fact that shows how opioid abuse cascades through social networks. Eventually, it destroys those networks as individuals withdraw into isolating darkness, the kind of isolating darkness that is uniquely produced by this kind of addiction. The carnage produced by this opioid abuse crisis is plain for all to see. A fresh horror story can appear on the evening news every single night, almost regardless of where you live in America. And while we focus on the deaths, we shouldn't forget about the toll that addiction takes in other forms on the living. Across the country, foster care systems are overwhelmed by what you might describe as children who are effectively refugees from opioid-addicted parents and households. Babies are born dependent on drugs that may one day claim the lives of their parents. Countless other people spend sleepless nights praying that they will get back the husband, the wife, the son, or the daughter they seem to have lost to opioids. These examples show that far from being a victimless crime, drug abuse itself produces countless victims. It corrodes users, households, communities, and entire countries alike. When faced with a crisis of this particular magnitude, it's easy to say that maybe the solution can be found in a new raft of government programs. I don't offer any easy solutions like this today. In a way, I wish that it were that easy. I wish that we could do that. I wish that we could just push this button to say, end this crisis. This is too complex and too intricate an issue for knee-jerk responses. Instead, I offer up two rules of thumb that I think ought to guide us as policymakers, as people who are involved in public policy discussions as we move forward. First, do no harm. There's strong evidence that the government has itself done substantial harm by, among other things, paying for a flood of pain pills through Medicaid and the Medicare prescription drug benefit. Before we jump into any other government-funded solution, we should reckon with the damage that this kind of mentality and this kind of programmatic response through our nation's capital has already caused. Second, we have to recognize that culture matters when it comes to drugs. The medical community has already started to change for the better, as doctors have created and in some cases reestablished norms against the reckless prescribing of opioids. As a result, opioid prescriptions have been declining for the last several years. Fewer prescriptions means fewer loose pills that can go into general circulation and end up creating addicts. So these things represent a tangible, positive step in the right direction. The harder task really will be to change the broader culture within American communities and families to make them more resilient to drugs. As forthcoming research from the Social Capital Project will document, drugs erode communities, but they're more likely to spread in communities that are themselves already in the process of being eroded. The already eroding communities are especially vulnerable to this. Likewise, drugs isolate the drug user, but they're more likely to entice those who are already feeling isolated. If we're going to halt the spread of opioids, and if we have any hope of stopping the next drug crisis, then we need to build resilient families and resilient communities. That's a project that can be accomplished only at the community level, only at the personal level. Back in Utah, I've had the privilege of learning about 2 treatment programs that help vulnerable citizens overcome addiction and a lot of the behaviors that come along with addiction. The first is called Odyssey House. It's a not-for-profit group in Salt Lake City that treats a variety of substance abuse issues, although opioids represent, of course, its biggest challenge. Odyssey House helps to divert substance abusers away from the criminal justice system through drug courts and other programs into a supportive environment where they can detox and, just as importantly, prepare for life outside of addiction, after addiction, for helping them see what comes next. Odyssey House has worked hand in hand with local government and civic groups to serve the local community, and they've done so with a great deal of success. When local law enforcement began cleaning up a heroin-addled neighborhood in Salt Lake City known as the Rio Grande District, Odyssey House stepped up by adding 112 treatment beds. The second program is called the Other Side Academy, which is designed for individuals who are a little bit further along in the recovery process. They've already detoxed, but they want to make sure that they don't go back to the old behaviors. The Other Side Academy does not offer medical treatment. Instead, the Other Side Academy offers a sort of life-changing program. It's a 2-year residential program in Salt Lake City that teaches troubled individuals how to rule themselves and how to contribute successfully to society. As its students advance through this 2-year program, they work at one of the several not-for-profit business enterprises supporting the Other Side Academy. These enterprises include a thrift store, also a food truck, and also another business that happens to be the top-rated moving company in the Salt Lake City metropolitan area. They're the moving company of choice now because people have learned they do such a great job supervising their employees and taking ownership of the kind of work that they provide. I had an opportunity to visit the Other Side Academy just a couple of weeks ago, and I see it as a kind of model of what a supportive therapeutic community should look like. The students look out for each other, and they work their hearts out to sustain the academy. And this year, for the first year in its 3 or 4 year existence, they're going to bring in enough revenue to keep them sustained. In other words, it was started with a charitable fund, an endowment by some generous donors. And little by little, they've been working their way up towards self-sustainability. This year, for the first time in their existence, they will be funding all of their entire operations. This positive culture of accountability helps the students at the Other Side Academy get to the other side, and not just get there, but stay there. 5 years after its graduation, more than 2/3 of the Other Side Academy's students are crime-free and drug-free. At regular prisons, the experience is roughly the opposite. 2/3 are rearrested within 3 years. So they're doing something right there. And these are just 2 programs that are making a difference in my state, in Utah. And the examples could be multiplied. There are other programs like Odyssey House and like the Other Side Academy cropping up all over this great country. And they're doing so because of the greatness of the people who inhabit this land and their dedication to building stronger communities and helping individuals who have been saddled with this very complex and painful burden. Every day, local
Just go ahead and state your name and ask your question in the form of a question, please.
Hello. My name's Jacob Rich, and I'm just curious, with the advent of fentanyl and heroin outpacing prescription opioid deaths for the first time in American history in 2015 and 2016, how are we looking at the prescription drug monitoring programs, which have successfully decreased the number of prescriptions distributed in the United States since 2011, since it seems that the black market deaths are now outpacing the prescription deaths?
Yeah. It's a good question. So you're right. So the rates the rate at which opioids are being prescribed is down. And yet, at the same time you see that occurring, you also see the number of people dying from illegal fentanyl, from fentanyl as it's being illegally imported from China and then used either through pill mills that are selling fentanyl as fentanyl or using it as a cutting agent for something else, seem to be on the increase. This suggests squeezing the balloon at one end is pushing some of the air into the other end of the balloon. I do think if we can continue to make headway when it comes to prescribing practices, including, by the way, some of it is it's not just, nobody wants a doctor who is willing to look a surgery patient or a terminal cancer patient or someone who is in genuine acute need of pain management. Nobody wants them to turn people away and say, no, too many people have abused this, you're not getting this. It's that in many instances there are other forms of medical intervention that can help. And if you address the underlying issue, you can make the pain temporary rather than tolerable over the long term. And so with the way we compensate many medical practitioners today, it is almost incentivized a rush process. It is much easier to write out a prescription for 90 tablets of this or that opioid and send the person on his or her way than it is to talk through other treatment strategies that might take more time but involve less reliance on that. The hope is that if we can get fewer of the prescribed substances out there in the market, we've had a massive flood of them for a variety of complex reasons, some of which had to do with the expansion of government programs that made it easier for people to gain access to them. But if we can get the rates at which they're overprescribed down, perhaps that will at least stop fanning the flames of new addiction. It is much, much harder to control because of the potency and the potency that we could almost come to expect because of scientific advancements coupled with this thing I referred to known as the prohibition effect, with greater degrees of potency being achieved. That's really, really hard. I don't know of any technology, any mechanism by which we can stop envelopes as they're traveling through national or international mail systems and say, we've got fentanyl in that package. But we can at least stop fanning the flames through our prescribing practices. Thank you.
Senator, thank you. Thank you for being here today. Appreciate it. Thanks so much.
Good to see you.
Yeah, you bet. Thank you, Senator. So if we could have the panelists come up, I'll introduce Scott Winship, the head of the Social Capital Project, and he can introduce Yuval and Sally to you, and we'll continue with the program. Thanks.
Okay, well, thanks for coming out. Thanks for joining us this afternoon. Appropriately enough, I've been hobbled by some back pain the past couple of days. I've only treated it with ibuprofen, so it's a real treat to moderate this panel with Sally and Yuval. If I do my job right, I'm just going to ask them hopefully the right questions and allow their brilliance to shine through. But I'm very excited to share a stage with them. Let me start just by introducing them to you. Dr. Sally Satel is a resident scholar at AEI and the staff psychiatrist at a local methadone clinic in D.C. Dr. Satel was an assistant professor of psychiatry at Yale from 1988 to 1993, remains a lecturer at Yale. She's written widely in academic journals on topics in psychiatry and medicine, and she's published articles on cultural aspects of medicine and science in numerous magazines and journals. She's testified before Congress on veterans issues, mental health policy, drug courts, and health disparities. Dr. Satel has authored, co-authored, or edited 6 books, including her most recent, co-authored with Scott Lilienfeld, Brainwashed, The Seductive Appeal of Mindless Neuroscience, Basic Books, 2013. Yuval Levin is the vice president of the Ethics and Public Policy Center and EPPC's Hertog Fellow, and he's the editor of National Affairs magazine. His essays and articles have appeared in numerous publications. He's a contributing editor of National Review and the Weekly Standard, a senior editor of EPPC's journal, The New Atlantis, and most recently author of The Fractured Republic, Renewing America's Social Contract in the Age of Individualism. He is a recipient of the prestigious 2013 Bradley Prize for Intellectual Achievement. Before joining EPPC, Mr. Levin served on the White House. Mr. Levin served on the White House domestic policy staff under President George W. Bush. He holds a BA from American University and a PhD from the University of Chicago. Let's see. And then before we start in, I just want to acknowledge my team members in the audience, Christina King and Daniel Bunn, who did the bulk of the work on opioids for us. It's a report that they spent a lot of time on. I'd really would recommend that you take a look at it. Okay, so let's jump right in. So Sally, how did we get here? What's the condensed history of the opioid epidemic? How did it sneak up on us?
I'll give you the public health version, and then you all could give us the cultural version. And the senator already previewed the cultural version. So in the 80s, in the 80s, a pain movement to treat pain more effectively started to grow. At the time, physicians were afflicted with what one doctor called opiophobia, this fear of prescribing medications, even sometimes to cancer patients, but certainly to people who had chronic non-terminal illnesses. And this led to a lot of suffering and a lot of needless suffering. This was in the hospital, not let alone take-home medications that they were too overly cautious about. So fast forward to about the late 1990s, early 2000s, the pendulum swung way to the other side. Pain became a fifth vital sign that was proposed by the American Pain Society. The Joint Commission on Hospitals and JCHO, hospital organizations, incorporated, none of these wasn't a requirement, but certainly incorporated an expectation that pain would be treated adequately. And then, pharmaceutical makers were certainly marketing, and some would say far too aggressively marketing. Others, that's a big matter of debate. But there have been lawsuits in the past, and certainly now there is a huge legal issue that a federal judge in Ohio is assigned to resolve, 550 cases. But in any case, I would say the movement to treat pain more effectively, plus the provision of new medications to resolve pain, and also another factor was that doctors were actually judged on how well they treated pain. This became patient satisfaction surveys were taken very seriously by various insurance entities, and doctors never got time to really talk to their patients about what could be underlying their pain, and there weren't a lot of alternatives that were promoted, let alone covered by insurance. So all these factors combined to lead to I think it's fair to say a crisis of overprescribing, which incidentally the CDC did not recognize, at least officially, until 2011. So that was the beginning, and doctors did have a bad habit of giving a bottle of pills when, if you have your tooth extracted, you either needed a few days or maybe not at all. And it wasn't so much, and I'll just wrap up here for this, about this background, but it actually isn't so much an issue that patients who are prescribed these medications for short and even for long-term non-cancer, non-intractable pain, it's not so much that they become addicted, but that the excess pills, if they're given a bottle, that excess gets diverted into the population, and that feeds abuse in the communities. I should say, certainly people who are prescribed these medications legitimately can get addicted. I'm not saying that never happens, but it's quite likely that when you take a careful medical history and psychological history on such patients, they've either had a problem with addiction of some kind in the past, or they're struggling with depression, which you could imagine could accompany a chronic illness, or PTSD. One wonders about all those soldiers in Vietnam, and also, as the senator mentioned, the great spiritual dislocation that happens. which is in some sense mirrored today in certain communities for other reasons. But those are the people at risk, and doctors have to pay attention to those risks. But the major abusers of drugs are not actually patients. And I'll just close up by saying, and it's also important to realize that prescription pills, while I think it's fair to say they did help kick off the crisis we have, are no longer driving it. It's definitely heroin and fentanyl, which is incredibly potent, 50 times as potent as heroin, as you mentioned.
Yuval, you've been a policy veteran for most of this period that the crisis has sort of blown up. Can you give us a sense of your impression of how health policy may have contributed to the crisis itself?
Yeah, well, thank you. First of all, thank you for involving me in this conversation, and thank you for the JAC project, which I think just by helping us see the connections between these kinds of problems and the question of social capital really helps to shed a light on a piece of this story that's often left invisible. On the policy side, I think Sally got at a lot of it. There was a kind of change of attitude in American medicine that came to be reflected over time in health policy. The emphasis on pain relief, on chronic pain relief. In every hospital room in America, you'll see this chart that says, rate your pain, and it's like a smiley face and goes to a, whatever it is, some kind of crying face with a deep frown. This is a distinctly American thing, and it's a very unusual way to think about the role of pain relief in healthcare. And it was very much encouraged by public policy throughout this period. I think that the FDA played a role in the original kind of prescription side of this problem that now the agency itself has recognized and acknowledged. Beginning in the mid-1990s, in 95, the FDA approved what they called controlled release OxyContin, and they actually said that it was not addictive. And the label said that it was not addictive. And that turns out just not to have been true, and OxyContin became a huge driver early on of what became this kind of opioid abuse crisis. And the agency didn't really get control of that until really the last few years, 2012, 2013, when they started to pull back on some of these approvals. So certainly public policy played a role. The VA in treating veterans coming back from Iraq and Afghanistan treated chronic pain as a health crisis, and the result was that a lot of veterans did find themselves with a lot of pain medication, and that seems to have contributed some to this crisis. But I think to say that it was driven by health policy would be too simple. It's not true. It certainly played a role in this, but a role on the supply side that has been important. But I think that both, on the one hand, the changes in the culture of American medicine that Sally talks about, and on the other hand, the demand side has to be understood at least as well. Solving the FDA's problem is the simple part, and I think that the agency's actually done a very good job, both under its last commissioner and especially under the current commissioner, at trying to get some control of this. But it's just not the case that solving the problem just means reversing its causes. This is such a multifaceted and complicated problem that I don't think health policy, whether it's getting control of prescriptions in Medicaid or whether it's the FDA, is really going to end up being the way that this gets addressed.
Sally, I also wondered, occasionally debates around Medicare, Medicaid, prescription drug policy have come up. Can you say something about the extent to which those programs exacerbated or really weren't a big part of the story?
Well, I think they are a big part, in a good way and a bad way. The negative contribution, and there's a very good report from the Homeland Security Committee, which came out in January, I think, documented in a quite persuasive way, I think, that Medicaid certainly contributed to, some pill mill operations, some really egregious overprescribing and continued repeat prescribing for patients who clearly were, not dealing with legitimate pain and probably were selling it. And in fact, if you read Dreamland, there's a whole what I call ox-economy where people went to pill mills and bought an enormous amount and sold them back home or bartered them. People paid rent with them. It was really very, very dramatic. On the flip side, the Medicaid expansion also expanded treatments, so that's a good thing. One thing, just to bring up Medicaid, that I do, this is Medicare actually, but in the rush to, prescriptions look like, believe it or not, in the scope of all this complexity, as you've all mentioned, prescriptions actually look like an easy thing to do. And many states, over half, have restrictions on how many days of pills. Some have actually, I believe, morphine milligram equivalent limits on how the volume of painkiller one they can give over between 3 and 10 days. I think that's the range, depending on various states. But now the feds are looking at that, a 3-day limit. As a physician, I think that's a bit of an overreach. Plus, you could argue the states are already on it. But CMS is looking at a 90 milligram limit a day. I won't get into details, but if you're really in pain, 90 milligrams isn't that. I mean, it's within reason. Some colleagues and I have been discussing the issue with them. They seem receptive to thinking about it. One more thing, though. There's a flip side to this now with the other pain crisis, which is people who are now victims of what has kind of blossomed into almost a persecutory climate about prescribing. So yes, it's true, doctors still prescribe. Some doctors still prescribe too much. As the senator mentioned, though, the levels are going down. They're not plummeting, but they are going down. They're going in the right direction. And still there are patients who have chronic pain for whom nothing else works. Some of them are on what look like terrifyingly high doses, but they get out of bed with it, they go to work with it, they're productive citizens. And they are in great peril. Their doctors are now dropping them. Pharmacies, everyone's afraid. And they're afraid of, frankly, they're afraid of the federal government, but a lot of it started with the CDC guidelines, which were produced in 2016, and they're pretty good guidelines. They're fine, and the word is guideline, except they've been interpreted as mandates. And it's, as I said, it's just fomented into a very hyper-cautious climate that is, I think, hurting some patients too. It may protect some patients, but hurting some too.
Yep, absolutely. I want to make sure we get into the social capital aspects of the epidemic that Senator Lee highlighted. Yuval, last May, in a very memorable JEC hearing, you testified that, quote, "We have set loose a scourge of loneliness and isolation that we are still afraid to acknowledge as the distinct social dysfunction of our age of individualism, just as a crushing conformity was the characteristic scourge of an era of cohesion and national unity." Can you say more about that and about its relevance, potential relevance for the opioids crisis?
Yeah, I mean, to get into it from the question of the opioid crisis, I think it's worth taking note of the fact that this is an epidemic of downer abuse. That is, it's not people taking drugs to intensify their experience of life, but to provide relief from pain, and not just physical pain, relief from despair, relief from a kind of crushing pain that is, I think, part of far too many people's experience in our country. And it has to do not only with what we would think of medically as chronic pain. It's an epidemic that's connected at some level with a collapse of connectedness, with a loss of meaning, a loss of fulfillment in people's lives. And so we have to think of it in terms of people in pain. And a key part of the reason for that kind of pain does seem to be like something like social breakdown, a loss of family and community networks, a loss of work, which hits people not only in economic terms, in terms of not having enough to take care of their family, but not being needed, not having a place, not having a role. And we can describe this, I think not unreasonably, as something like a collapse of social capital. But that is a way of highlighting the complexity of solving a problem like this, because to say that something is a function of an exhaustion or collapse of social capital is to say that we are essentially at a loss about how to replenish it. Replenishing social capital is not a matter of reversing the causes of its exhaustion. You can't just say this happened because these social phenomena occurred and families broke down and we need to reverse them and rebuild family. It doesn't work that way. Social capital is built up very, very slowly and gradually in people's lives. It's built up through the building up of habits, the building up of patterns of living, of expectations. It's a matter of building up trust and of being trustworthy, of building up responsibility, of building up the habit of seeking help and offering help. These are things that are about character formation, and they require formative institutions. Those institutions are what we've been losing, but that means that bringing them back is a generational project. It means that getting people to be formed by these institutions that now are lacking in their lives is going to take a long time and a lot of effort. And that requires a long-term commitment. It requires an understanding that what's needed here is a kind of community and institution building that isn't going to have an immediate effect. And so, as Sally says, there are elements here that we can just take care of. We can change the rules about prescribing medicine. That can be done, and it can help. But if the problem is that too many people are living in circumstances where the essential prerequisites for thriving, family and faith and community and work, are not there, to fix that problem really requires community building. And that means that it requires a commitment both from government and from civil society and from all of us individually that's going to take a long time to work itself out. And, I think that is one big reason why we're seeing this kind of epidemic at this particular time. As Senator Lee suggested, it's something we've seen in the past when there has been a kind of breakdown of social norms and community life. We saw it in the very same parts of the country, in the Midwest and in the West, in a period of industrialization 100 years ago. We're seeing it now in a period of kind of deindustrialization, and they're related. They have to do with one another. That doesn't mean that the drivers are fundamentally economic in the most materialist meaning of that term, but it is a combination of economic and social and cultural and spiritual that makes it very, very hard to address as a public policy matter.
Can I just?
Sure, please.
That's a very eloquent platform for my saying. That's why I find it almost more useful to think of drug addiction as a symptom and not a primary disease on both the communal and individual level. I mean, you have kids in Bethesda who have jobs and probably are doing well in school and have all the outer markings of someone who's headed for success, but inside, for whatever reason, and it's so highly individual, but we can't point to anything dramatic. They have an intact family and enough material support and people who love them, but for some reason there's an inner hollowness as well. So that's always been a problem. It always will be a problem. And I used to think kind of more romantically about opioids, in that they're, we have depressants, which someone mentioned the opioids and alcohol at higher doses, and barbiturates and Xanax and the benzos, what they are, and then there's the stimulants. But I always thought of opioids as oblivions, and in fact, that's how a lot of people talk about it, and that's if you take a high enough dose. But if you take a low enough dose, or you don't take that much, people actually can function, and that's usually a phase of the course of addiction, and then it gets out of control. But my point is that before stimulants, before heroin, there were stimulants. And if you read Methland, which is you should read Methland and you should read Dreamland. Methland came out in 2011, I think, by Nick Redding, and it was about the methamphetamine epidemic in Iowa and in that part of the country, Missouri. And there are whole passages in that could have been in Dreamland. That same, the same sort of desolation, the same kind of dynamic of defeated people in defeated places, And it's just that drug doesn't kill people. It does, but not nearly as much as heroin. And people mix their heroin a lot with that. You have a great chart. I should congratulate you on that report. You have a wonderful chart of toxicologies of people who've died from prescription medication. More than half of them have more than one drug in their system at the time, mixed with alcohol or Valium, Xanax, this sort of thing.
I should say, as Sally suggested, talking about the kind of student in a well-to-do neighborhood that clearly suffers something that's not obvious, even social capital doesn't quite get at the kinds of problems that people are dealing with in taking up opioids. The very fact that this is such a problem in Utah, as Senator Lee suggests, if you could say what is the ideal goal of social capital policy in America, I would say it's to make every state like Utah, where families are strong and divorce is low and birth rates are high and all that. And yet, Utah has enormous problems with opioids, and those problems do have to do with a certain kind of breakdown in social capital. But it helps us to see that even the ways we have of measuring these things don't exactly get at the deepest problems that people confront, and the ways in which the culture writ large leaves people isolated and lonely in ways that leave them looking for relief.
Let's get back to policy. So, Yuval, in your view, what, if anything, should the federal government do to address the opioids epidemic? And sort of elaborate on this question you raised earlier about whether the federal government can actually do anything to promote social capital or the revival of civil society.
Yeah, well, so those are in a sense two separate questions. I mean, there's certainly things that the federal government can do, as we've been saying, to help with the opioid epidemic as such. Some of those are being done, reforms at the FDA and reforms of prescription policies. I do think that there is room to invest more in the treatment and intervention policies that seem to be effective, and so there's room for trial and error there and for seeing what works and under what circumstances. And so, I was inclined to resist just turning every problem into a reason for more spending. But look, this is an area where some spending seems to be effective, and we need to find out where that is and what that is and think about how to make it available to people. I also think that there has to be more of an effort to keep fentanyl off the streets. It's true, as Senator Lee says, that we don't have a good technology for figuring out exactly which package in the UPS stream is bringing in fentanyl. But there are ways that the federal government can take this on more aggressively, and that just has to be done. Fentanyl comes in from abroad, generally from China, and there have to be ways to gain control of that stream. It's putting Americans in danger. Beyond that, the social capital problem, I think that's a lot of what you at JC and what others have been trying to think about for years. I don't think it's entirely true that government has no role to play in building social capital. But the role it plays is certainly limited, and it's especially limited at the national level, where what really has to be thought about is how do we create the space for social capital to be built up at the community level and at the interpersonal level. I think that has to do with empowering the institutions at that level to have some effect on social policy, on education policy, on welfare, to allow what happens on the ground to matter. Will tend to drive people into those spaces on the ground, and so will tend to build up the kinds of networks and institutions that are necessary for building up social capital. That is a very indirect way to be useful, and I think that for the federal government, there are almost only indirect ways to be useful in building up social capital, but we shouldn't underestimate how important this could be. At the state and local level, and especially at the local level, there is really a lot of room, I think, for public policy to make a difference in drawing people out of their narrow circles and into something that looks more like interpersonal, communal involvement. Again, giving people ways to be useful. A lot of what this kind of crisis is about is people feeling like they are not needed. And that is not an easy problem for public policy to solve, but I do think that if we saw the problem in those terms, we would have an easier time seeing ways and opportunities for people to become more engaged and more involved and less alienated from the world around them in ways that would make a difference. That's not a simple solution, but it's at least something.
Sally, what about you for policy? What's the right balance of prevention and treatment and punishment and demand management, I guess?
I still don't know how to prevent this if you're thinking of prevention programs. You've all outlined a prevention program, but that's not something that you do in a 20-minute school. But schools can be part of it. I mean, teachers, having a relationship with one teacher can really save a kid. having school programs, cohesion in a school being one of those institutions that you've all referred to. More immediately, I would spend a ton of money on treatment infrastructure. It's not, it's highly uneven across the country, and we do have, kind of the irony is we have 3 really good medications. Everyone talks about the medications. Methadone, which has been around forever, but it's very effective. And now, for the last, going on almost 2 decades, something called buprenorphine or Suboxone, where the doctors can give that in their office. Methadone can only be prescribed through a clinic. And then there's a third drug called naltrexone or Vivitrol, and that is actually delivered as a shot. And unlike the other 2 medications, which are opioids themselves and do have some street value, and there is a bit of a problem with buprenorphine diversion. However, it's not that easy to overdose on it, which is why doctors are allowed to prescribe it out of their office if they take a test. So those medications are great for stabilizing people. They suppress the first 2, which are opioids, suppress withdrawal. All of them suppress craving. So that's great, but a person has to be motivated to stick with it. And that's not enough, clearly. Once someone's stabilized, then the whole repair process, kicks in. Starting to rebuild those bridges you burned with your family, and it would work, and at school, and this is what rehab is called, and that takes a minimum of a year. So a week in a detox clinic is, in some ways, the worst things for you, unless you transition into either a residential or a very, very attentive outpatient program, because then 5 days off drugs, then your tolerance goes completely down, and certainly your life hasn't changed, so you very high likelihood of resuming drugs. So that's bad. So these take a year. We have to put a lot of effort into all these gaps along the way where people drop out. You've heard of Narcan. People, it's a great thing. It really is like a Lazarus-like, practice where you give people this antidote and they do wake up immediately. Sometimes they need many doses if they have fentanyl, and but a lot of times, I know at least half, they just walk away. In some states, I think, or cities, they're required to be brought to an emergency room, but then they walk away. Or if they stay, and they're convinced to go to treatment, and lots of places are working with recovery coaches, people who've already been through this, and they meet them in the ER, and they say, look, I've been there, I can do it, you can do it. They even lose those folks, although they keep trying to follow them up, and then you have someone who goes to treatment and stays a while, and they drop out. So while that sounds sort of frustrating, and it is very frustrating, I also have to say that every day in a treatment program is a good thing, because you're doing less bad things. You're less likely to get arrested, you're less likely to show up in an ER, you're more likely to spend some more time with your kids. You may work at your job, even if it's off the books, but at least you're productive and busy, and more of that. And so every day is more of that, and all kinds of cost-benefit analyses show it's always worth it. And typically a person comes in, they have that experience. If they drop out, at least they're, what's the opposite of inoculated? They're primed to come back again later on.
Okay, I might ask one more question, and then I think we'll have probably 15 minutes or so to open it up. So lest we neglect civil society, are either of you aware of innovative models or approaches at the local level? Senator Lee mentioned a couple of programs in Utah. Anything you see that sort of looks like a candidate for scaling up that might stem the tide at all?
Well, I will put it a pitch for the criminal justice system and all of this. And that is, sometimes it's scalable, sometimes it's not. Rural areas, it's tough. I mean, that's potentially a place for telemedicine. But the criminal justice system, I think, deserves a big pitch, because we hear almost every day, you hear someone say we can't arrest our way out of it, and then I bite my tongue a little bit, because while I prefer people to say we can't arrest our way out of it, I don't think, we can't incarcerate our way out of it. We can't incarcerate our way out of it. That's true. But if people break the law, if they shoplift, if they mug someone, if they steal, if they neglect their kids, that's a crime, and they should come under the umbrella of the criminal justice system, but in a way that diverts them into drug treatment. And I think it's a very powerful combination, and drug courts are one example of that diversion, where there is a kind of structure imposed on them and a kind of supervision and consequences built in that tend to keep people in a treatment program longer, so they can get the benefits of it longer, with the carrot at the end that the charges will be dropped. And they're at least a year long, most of these drug courts, and they're associated with rehab programs and vocational programs, and it's potentially, especially paired with these medications I talked about, medications that don't exist for really any other addiction, should be, in my view, a pretty powerful combination to help people stay, really get on the path to recovery. The data are not in yet on drug courts that do work with the medications, but I'm optimistic that they'll be, they'll show good results.
Anything to add?
Well, I would just warn against looking for things to scale up. I think that oftentimes solutions that work at the local level are just going to work at the local level, and we have to be grateful when they do, and look for ways to maybe help other places learn from that experience and apply them to their own circumstances, but not necessarily think in terms of taking them to a higher scale, because that's often a way to make effective programs less effective. I would also say, in terms of looking for ways to draw lessons, the sheer fact, as Sally suggests, the sheer fact of the existence of effective medications for treatment here makes this different in a way that we ought to think of as promising from a lot of past drug epidemics. And that means that there is here a target for investment, including for an investment of public money, that is actually quite different from what we've seen in the past in terms of drug treatment. And, again, money is not a solution for everything, but it is a solution for a lack of money. And there are places where the problem really is a lack of money, where these solutions exist, and the reason they're not being made available to people is that they're too expensive for the locality to afford. And there, I think it does make sense to try to provide them with the resources they need. And there are states that are trying to make this work. Ohio is trying, for example, in some experimental ways, to make federal money that's intended for other things available for this in ways that could help. I think that kind of thing is very well worth trying. And we should look for places to make the most of the opportunity that's available thanks to the existence of these drugs.
Death penalty for drug dealers, pro or con?
Of course, no. But it was kind of a shame. I was at that opioid. Were you at that summit? And it was choreographed, but it was good. I mean, and I was very impressed with the Secretary of Health and Human Services. He really laid out, as you say, the needs and the things that money could really help with. And there was a great deal of interest and commitment. The people spoke quite passionately. The other secretaries, and so it was constructive. And then when I don't think he was expected, but then the president came in at the end and sort of stole the spotlight with the executing drug. It was kind of a shame because the other what had gone on didn't get much coverage at all, I didn't think.
Yeah, the report from the President's Commission is quite detailed. I think they have
56 recommendations.
Yep, absolutely. Okay, we've got about 15 minutes for questions. If no one asks questions, then I can scrape the bottom of my barrel for what I was going to ask Sally and Yuval. Right here. Yep. No, I'm sorry, above you. Yep.
Excellent presentation. I'm Bernardo Rico, of President and Founder of Smart Drug Policy. I wanted just to pick up on the kind of destruction or demise of the social capital element, and in my opinion, how that's not something that will take a generation. It's going to take at least 2 generations, if not 3 generations, if you think about what's happening in the U.S. economy, the globalized economy. I don't see that changing anytime soon. I think one of the big things, and not everyone is willing to recognize this, that we need to identify another kind of recurring problem, which just is kind of simply the drug culture in the United States. It's unlike no other in the world. So while there are people who go through despair and whatnot in different parts of the U.S., and as well as the other parts of the world, those people in other parts of the world, in Latin America, what have you, are not necessarily using the multitude of drugs that are available to people in the U.S. And I think we need as a country to go back, starting with what the Senator mentioned, looking at the Civil War, how drug culture evolved and kind of ebbed and flowed and brought us to this point today. Because if we don't, 10 years from now, 20 years from now, we're going to be talking about another drug crisis, maybe even worse, some type of synthetic that's even more potent or more deadly. So how would you bring that into the discussion in terms of recognizing kind of a recurring drug culture in the United States?
They meant that for you.
Well, it's a very hard question. I think, first of all, there's a way in which we can understand that problem as the problem of a country with high economic capital and low social capital, so that the social problems we have are dealt with through drugs in our country, in part because we have the money for drugs in our country, and we certainly don't have a monopoly on isolation and despair, but we have the resources to deal with that in ways that look more like a drug epidemic than some of the quite serious problems that other countries confront when they deal with crises like this. So you might say the United States has been living through a long series of drug crises for a very long time. Some of these have been opioid crises in the middle of the 19th century, at the end of the 19th century again. Some of them have been other kinds of drug crises. And it's true, we have a kind of drug culture that, while the means have changed over time, has been a living, intense drug culture in America for a long time. That's, in one sense, a way of making the problem seem so big that it might drive us away from trying to address it. Because although it is, in a sense, a large national cultural problem, it actually is also a person-by-person, life-by-life problem that can be addressed at the scale of the individual and the family and the community. And at some level, we have to address it that way. It would be good also to think about whether there are these sorts of mass cultural solutions that might help us out of this. I don't know if there are. I'm not aware of any. But I think we've got to be very careful not to let the scope of it keep us from helping people one by one where we can.
I was, before this event, I was looking at some cross-national statistics, and the U.S. is just an incredible outlier when it comes to drug overdose deaths. I think Canada is number 2, and we have 2/3 more deaths after you've adjusted for the fact that the population...
There's a combination, on the one hand, of freedom and of the kind of character of our medical system, and just of wealth. This is something we confront all the time in healthcare policy, where people say, well, we spend so much more of our GDP on healthcare. That's almost entirely explained by the fact that we're actually much wealthier than the other wealthy societies. We tend to think of ourselves as being in this class of big economies, of wealthy economies. We're more than 20% wealthier than the second wealthiest society in the world. And so the United States does have some distinct problems that are oddly problems of very well-to-do societies. Some of them are quite serious and are very hard to deal with. But, again, we can't let, as I say, the scope of these things keep us from understanding them also as just human problems.
Maybe one of the consequences of wealth is an intolerance of, or a very kind of a low threshold, or lower than other, comparatively lower threshold for discomfort of any kind. And one thing I do worry about, I mean, you're talking history, I'm talking about immediacy of, all the kids in school who are I'm not saying ADHD isn't real, and I'm not saying that kids aren't depressed, and that when they are, there are medications that can help them. But as I think everyone knows, a lot of these medications are given to kids who don't really need them. And I'm not even talking about the sharing of meds, but I'm talking more about the ground that's yet again laid for an expectation of a pharmaceutical approach to all kinds of stress.
Yes, sir.
Carl Pulzer of the Center on Capital and Social Equity. It's a project that explores and encourages inclusion, both cultural and economic. So I heard about Medicaid, but I kind of want a little more nuanced thinking on it. I think there's a bit of a political block here. There's a bit of a problem with Medicaid expansion. That conservatives were reluctant to confront the difference between Medicaid is an opportunity, if it's expanded, to better manage opiates. That is, the federal government could hire a managed care company to really be more sensitive to these pill mills and punish the states if they allow that to happen. So it's an opportunity. But there's a sense that, oh, gee, if we give these poor people coverage, then that might open up a problem. And I think that's a political kind of correctness that we need to get around. I think there's an opportunity for management here, and it requires covering that population. Just some comments. Thanks.
I think there's a question, woman back here. Yep.
Hi, Emily Top, Manhattan Institute. Thank you so much for being here. I had just like a quick question. So you guys both kind of mentioned cultural issues and kind of dealing with those and that taking time. What are your thoughts on like harm reduction measures and whether or not with time, if we build up like the social problems, if that would be beneficial?
Well, I do think harm reduction, like needle exchange, are you talking safe injection rooms too, things like that?
Just in general.
Oh, okay. Well, harm reduction, as the name implies, is the kind of it's a philosophy that kind of accepts that people will do risky things, or they're not ready to stop doing risky things, even if they want to, on some level, but that we should make it sort of safer for them to do these risky things. So, of course, that's where Narcan comes in, and I've even heard dealers sometimes giving out Narcan and now people are encouraged to, even if they have, if they're worried about a loved one, to have it in their house. I read a story about a father in Sheepshead Bay who used Narcan on his son, 4 times over the course of a few months, but it saved his life. And anyway, so Narcan is a harm reduction measure. It's a Band-Aid and it's an aortic clamp. It keeps you alive, but it doesn't do much about the addiction, obviously, unless the person goes into treatment or stops. And some people do stop on their own, in fact. It's probably more common than we think, but we don't hear about it. And obviously deaths and all, are going to get our attention, understandably. So there's that. The needle exchange, which is really important now, especially for hepatitis C, which is highly infectious. I know that, I certainly, the most famous one recently is that one in Indiana that Governor Pence, then Governor Pence, came around to, but they're important. And then you get into the more controversial versions of them. One is called, there's several names for it, safe injection facility, safe consumption rooms, but the basic idea is that people who use drugs, this is mainly a product of really the fentanyl issue, can come into this place, which exists in some countries in Europe and in Vancouver. That was one of the first ones, I think. And they inject their drug then under supervision of a nurse who was right there with oxygen or Narcan if the person overdoses. And depending on where you are on the spectrum of harm reduction acceptance, some people say, well, of course, and others kind of go, that's insane, that enables it. And some people like me have a kind of grudging tolerance that I think I think, well, first off, I'm a fan of local control, so if a neighborhood really does think they need this, and Philadelphia is right on the verge, I think, of having one, I would support that, frankly, and, but if I were running the show, I would make it imperative that the University of Pennsylvania or RAND or someone study it, and that the researchers not be at all involved with the program, because there are studies of safe injection rooms. A lot of them are not prospective, and they're not done by independent evaluators. So I think we could learn something.
Right here.
John Soliday. Has the social climate of inclusion, where all lifestyles are acceptable, hurt our social cohesion and ability to address this problem?
So I think Yuval has written pretty eloquently, partly in one of the quotes that I had, I think, about how there was a lot of good and bad in the past. The good was that there was more security, there was less change, but the price of that was kind of this requirement that everybody conform, and that freedoms for a lot of folks were a lot more restricted back then than they are today, and so it seems like there really is a trade-off, that you can't have all of it, but we might choose to accept the costs that have come with more of the openness that we have, an individual freedom that we have. Yep.
Thank you. Megan Goodwin. I'm with the United States Conference of Catholic Bishops. This question is primarily for Mr. Winship. So given the historic role of religious institutions as the largest developer and sustainer of social capital in the United States, how are you engaging the faith community in your response to the opioid crisis?
So our project is only doing research. So we haven't touched policy or legislation at all, and probably won't for the foreseeable future. Senator Lee really gave us a mandate to just study the problem and understand it. He has a lot of smart policymakers that are way more qualified than I am to sort of write a bill about this stuff. It's certainly the case that if we want to sort of re-empower civil society, that religious institutions must play a central role in that. Robert Putnam has a book. He's got his book Bowling Alone that probably everyone's heard of. He also has a book on religion, where he notes that just a huge fraction of volunteerism, of charitable donations, are made by people who are tied to faith communities. So it's not even necessarily that they're volunteering at their church or they're giving to their church. They're in fact giving well beyond that. Utah is, the state I know best at this point. Utah is number 1 in the country in terms of its religious volunteerism rate, but it's number 15 in the country for secular volunteerism. So those tend to go hand in hand, and yeah, I think we can't really get anywhere with any of these problems of civil society unless we figure out a way to empower religious institutions. One more? Okay. Last question.
I would be remiss if I didn't get up and pitch Oxford House. As you talk about rebuilding social capital, Oxford houses are self-run, self-supported recovery houses for alcoholics and drug addicts. About 60% of the folks living in Oxford House are recovering from heroin addiction or opioid addiction. 78% have done jail time, averaging a year and 1 month. And about 80% will stay clean and sober. Last year alone, 35,000 people lived in some of the 2,346 Oxford houses around the country. The interesting thing about Oxford House is it can be easily replicated. Just like newlyweds go rent a house and start a family, recovering drunks and druggies working together can go rent a house and start an Oxford House. And they then tie themselves together based on the American traditions of participatory democracy and all that kind of stuff. And they really become believers in a new way of life. But because they accumulate no money and they accumulate no real property, they rent all these houses, they're able to expand in order to meet the need. So you can live in Oxford House as long as you want. There's been a few people who've lived in Oxford houses 25, 30 years. There's been others that lived there only a week or two, because part of the rules of the game is you're thrown out if you drink or use drugs. And about 20% are thrown out each year. So anyway, I leave you on that optimistic note, in that Congress, I think is kind of looking at this whole Oxford House thing and saying, how can we expand it without screwing it up? Ed Madigan in 1988 came to me when the Anti-Drug Abuse Act was being written and said, how can I put in a block grant for getting 2 or 3 Oxford houses in my district in Illinois, because we had 13 Oxford houses in D.C. And I went to the board of directors. The board of directors then was presidents of each of these 13 Oxford houses. And 8 of the presidents were African American, 5 were Caucasian. All of them said to me, Paul, you're going to screw this up by getting government involved. So I told Madigan that I'd created a bunch of Blackberry Goldwaters and they didn't want anything to do with government. He then told the story to Ronald Reagan, whose comment was, golly gee, does Nancy know about this? And,
On that optimistic note, I think we'll wrap it up. Thank you again for coming, and thanks to Yuval and Sally for being here.